Hi, my name is Eric Frank, and I'm with Snow Aces Medical. Thank you all taking time out of your day to join us. Whether you're new to BioXclude or have been using it for years, I think we'll all learn something new today as we have one of the leading experts on its use. I've had the pleasure of working with him for over 10 years. Please welcome Dr. Dan Cullum.
Thank you, Eric. It has been a pleasure. It's a great company. Well, welcome everybody. I trust you're enjoying Orlando, even with the extra steamy weather we've had, but it's been great, so welcome. Today I'm going to talk with you on just covering a number of areas of surgery to make things less invasive and more applicable, being able to do things as single surgeries or in a shorter time period. For disclosure, these are the companies that I've worked with and have received honorarium for, or work with designing instruments or other different applications. So this is my disclosure list, and so we'll get going with the regular talk now. A lot of times we learn in better atmospheres, and we've had privilege of doing a number of different courses. Heli skiing and in different ski stops. We've done snowbird a couple of times, and it's a great chance to get to meet folks and have camaraderie on a level that you don't always get. And it's amazing what kind of good ideas come up after skiing and a glass of wine or whatever as you're thinking things through. So we have a training center in Coeur d'Alene. Love to have you come visit us there if you have interest. The last course we have for this year is with Joe Kahn in a couple of weeks, and we're doing comprehensive immediate implants. So if you have interest, let us know. So for today, we're going to cover various minimally invasive applications of using dehydrated, deepithelialized Amnion-Chorion Membrane, which is a whole mouthful. I'll normally call it Amnion-Chorion. The product that we're showing here today is BioXclude. It was the preeminent one with most of the data that's out there and has been around for probably 12 years in dentistry. And before that, it's been with mimetics and medical and has had an application for years and years. So we're going to talk about some open socket grafting and simpler applications. And then we're going to go ahead and talk about immediate implants and more advanced applications. So I think one real key area that we've seen significant improvements in is wound healing and upregulation. And I think a big part of starting out with something is not to make it worse. And so in most extraction sites, not raising the flap, not taking out bone, learning how to do it sneaky to avoid scarring, recession, and more bone remodeling by being able to preserve the blood supply. Utilizing atraumatic extraction techniques, using X tools, proximators, a number of different kinds of instruments which allow you to mobilize the root without having to damage the bone. And so that, I think, is the hardest part of immediate implants, is getting the tooth out without wrecking things. So it does make a difference in managing wounds. A lot of the wounds that I get are dirty wounds with failing endo, fractures, apical abscesses. And so in any wound that's dirty, I rinse it out with betadine, like we as oral surgeons did in managing open compound fractures or messes like that. So I rinse it with betadine for 30 seconds, then rinse it out, re-prep it and clean it. And that's proven to be really effective with almost no loss and almost zero infections over a long time. Micro rongeurs, which are on the right, are really helpful to be able to get into wounds, especially single-rooted teeth, where you can get down inside the wound where a regular tip won't let you get at it. So a few minor instrumentation things. We go through normal wound healing, and so we want to enhance that. This, of course, is without a bone graft. It's obviously slower turnover if we've placed a graft in the site. So I think one thing that's super important is, as oral surgeons now, I mean, how many patients do we get anymore that aren't class 2, or half of my workload is class 3 ASA patients? They're on multiple meds, they're on all kind of challenges physically and living longer, enjoying life for the most part. We're also seeing a huge uptick in vaping with ridiculous concentrations of nicotine. And those all have influence on our wound, especially more atrophic or failed sites, or as we get into larger defects. So enhancing wound healing to me is something that I can do regular, easy, and predictable with very little cost. And so we'll talk about that a little more as we go. So when we look at a normal tissue regeneration triangle, and this paper was published by Sam Lynch a number of years ago, but hasn't changed, we have these varying components that contribute to wound healing with cells that come from the bone walls and periosteum, adding signal molecules or scaffolds, and over time we end up with an incorporation of the graft material and with healing. But the biggest thing is to get stem cells in the wound, and most are recruited from the bone walls. When we do add a signal agent, it really can improve neovascularization and stem cell recruitment and bone formation. And so I've used all BMP, PDGF, and Amnion-Chorion. I'm sure many of you have used those, and there's an application and a place for them. When we look at Amnion-Chorion, it's really not a barrier, it's really a growth factor carrier, but it does give containment like a barrier for 10 days, 2 weeks. But most importantly, it's packed with more than 250 cytokines and growth factors. And they are preserved in the Purion process and really bring in a ton of things that are beneficial to wound healing. So this is what first caught my eye. Then I learned there was a split mouth study, and they showed a reduced pain profile on the side treated with amnion. And we also know that the chorion layer has 80% of the growth factors, so we don't want to use an amnion product only because it has less of most of the growth factors. So an Amnion-Chorion product is great, and what the Purion process does is delaminates, it takes out the central spongy layer and then puts the amnion and chorion back together. They also expose the surface so that the epithelial cells migrate over top of it like a basement membrane, and that's really important, especially if we're missing a lot of tissue. So understanding that a Purion process graft, 20% of it is growth factors from the amnion and 80% of its growth factors from the chorion, but the other amnion products alone with non-Purion processed are even less than that. They only have about 5% of the growth factor of a combined Purion, amnion, chorion. So it's a little confusing with it, but you can see just the difference on the two screens where the thin amnion layer compared to the amnion chorion, and it does make a difference in the amount of growth factors. So we have lots of things that we use, but what's their diffusion profile? How are they released into the tissue? And with Amnion-Chorion, it's over 96 hours. So that's a 4-day release of growth factors on passive diffusion. When collagenase comes in, which is over the next 2 weeks, then it has a continued release. So you get a very biologic level of growth factor rather than a big burst at one time and no follow-up. And so that combined with all the growth factors in there really advanced the care. Now, this is one thing that got me excited when they published it, discovered is it's antibacterial. So if you put it on an agar plate, you've got a zone inhibition around it with these 3 drugs, AA, strep mutans, strep oralis, and also strep gordini. So it's antibacterial. Who doesn't want that in their practice? You know, it's a real help, especially on more complicated wounds and sick patients. So folks here, I'm sure, use PRF. Okay, I use PRF. I use it mostly in my third molar cases. When we look at PRF, anything that we have when we're treating a wound in the mouth acts as a scab. So the PRF clot, the epithelial cells migrate underneath it. They don't go on top of it. Whereas with placental tissue, they go on top of it, acting as a basement membrane. So what's the tissue difference that we have in a biologic width? You know, it's 1.5 millimeters. If we can have that, so we can see tissue margins come back up, and I'll show you cases of that as we do our talk today. The other consideration when we compare it to LPRF, nothing wrong with LPRF, it's a great product, I use it. However, the patients you need it the most on, the sick, systemically involved, multiple medications, how good are their growth factors in their platelets? Okay, so the people you need it the most on are the ones that have the most compromised systems and are not going to have as good a growth factor in their own platelets. Is it better than what they have without it? Yes, but if I can go to the shelf and take a product that has highly concentrated growth factors from childbearing age ladies, from their placenta, okay, that's going to be a whole lot better because the age difference straight out of the gate. So that's kind of the rationale. There are some other Amnion-Chorion products out there. Most of them are due through a freeze-drying lyophilization process, which makes them thicker because it expands them when they go through the freezing. So the Amnion-Chorion from BioXclude is very thin, which means it's not taking up space. So initially when you start using it, you go, geez, I wish it was thicker so I could manipulate it. When you flip it around and go, it's like a saran wrap. I've got containment and a high dose of growth factor with no space. I have more room for my graft material in the wound, if that makes sense. So this is one of the studies just comparing them, and in the bottom left corner was the BioXclude, and so for the other products, they don't have as good of inhibition and antibacterial properties. So this process doesn't have any detergents in it, no cryoprecipitants, and it doesn't have any freezing. It's very skinny, small, takes up very little space. It's immunoprivileged, it cuts inflammation, it's antibacterial, and it does help healing. And it's gotten me out of a lot of sticky spots. So I really utilize this every day in almost every case in my practice. So here's an example of a case that I'll show you a little bit later. And you can see on the mesial fixture in the first molar, we've got a fairly significant vertical soft tissue defect. The Amnion-Chorion or BioXclude is right onto the healing abutment exposed, and you can see that it healed with the same width of KT as the posterior site, which was an apical position flap. Okay? So I'll show you this case. Here it is after healing occlusally. And this is another case with immediate implants where we've taken out the teeth, placed the implants, grafted. The implants are placed in lingualized position for the screw to be in the center of the lingual cusp. And if you look at it on the lateral views here, you can see at surgery on the very first image, you can see the whole healing abutment, okay? After closure and then after 4 months, you can see that the tissues healed completely to the height of the healing abutment where it was exposed, and this is how the case finished up with a gingival margin and sulcus depth considerably above where it started out initially. So having the tissue heal over top of the basement membrane gives us an extra 1.5 millimeters, and if we shape it right and have the implant lingual, we'll see the tissue come up based on the biologic width and the bone level. So let's move into open socket grafting. And so this is a paper that I did with Mark Lucas from Denver, a periodontist. And so we did it around some extraction sites. Here's an example of using it in a patient that has a significant midline asymmetry and inadequate intercanine dimension to fit the 4 incisors. So we decided it was better to do her with conventional pros where we could use more camouflage and mirroring than with implants where we were stuck with margins and having to have adequate inter-implant bone. So we did her case, we grafted this. This is a blend of allograft and high temperature xenograft covered with the Amnion-Chorion, fit into the position, and then closed with here PTFE sutures at 4.0. Early healing at 7 days. You can see it filling in nicely and these wounds close up. Here's another 7 days. And so by 2 weeks, it's almost not really a wound anymore. And you can see the lateral heals faster than the central. That's because it's healing from the periphery with the epithelial cells migrating at 0.5 millimeter a day. A molar takes a little longer, obviously. So here is the patient after the grafting just for radiograph, and here's how she finished up with her pros, where the prosthodontist was able to shift the midline back to normal and get her into a relatively normal looking smile with conventional fixed pros. And I think there's definitely a role for that in our practices. So here's pre and post-op. Here's an example of how you manipulate the tissue. We place it, hit it with water, saline, and then tuck it into position. You don't have to trim it. It doesn't have to be perfect. Any extra tissue works fine. I think the key is just to make sure the amnion-chorion is a little bigger than the site. Additionally, we tie the sutures upside down so we don't knock it loose. So we come from the buccal through the palatal flap, and then to the buccal. We come from the palatal through the buccal, and then tie it in a figure 8. So an upside down suture works pretty good. PTFE works great. I use chromic on non-critical wounds because the chromic has the preservative in it. The preservative, if you get too many passes with the suture, can inhibit the amnion products and kill it. So I use chromic, but I don't use it on every case, okay? Ones I'm masking a lot of the wound, we'll tap it down. So again, you can see coming from the buccal through the palatal and the palatal through the buccal allows you not to knock the suture up. Okay. So here's an example of a patient that has a failing canine next to an implant. So we're gonna have to get this tooth out, and I had to chase it all the way to the apex because it was ankylotic, and you've had that happen to you in your practice. So here's the defect with vertical releasing incisions, and we can see I had to take bone to the apex to get it out. And now I'm doing typical cortical cancellous allograft. In the far right side of, you can see the amnion-chorion has been placed into position and hit with water, and now I'm just gonna close up around it. So here, I did not go for primary closure. All we've done is place the tissue back to its original contour, and you can see the dimensions of the old canine root in the site. We want to do that because that's going to give us a wider KT margin. So we're able to do most all of these without primary closure or near primary closure, depending on the wounds that we're facing. So here you can see it after 10 days, and you can see the limited inflammation that's in the area, and it's granulating quite quickly into the canine. So here's a patient after 4 months of healing. I've done local already. You can see that in the wounds. Now we're exposing it, placing the implant, and I'm only exposing it enough to do an apical position flap. So I'm gonna take the KT margin, move the thicker KT apical, make the vestibule a little deeper, and enhance it. We're laying another piece of BioXclude onto the facial of this underneath that apical position flap, put the healing abutment on, and that's how it looks. And you can see by using beveled incisions, the verticals don't show very much, and we've got an adequate inter-implant dimension so that we've got stability long-term. And this is the patient after 10 days of healing. Looks pretty good. And so this is a kind of limited inflammatory change as you see. So here's the patient after 4 months and being dismissed for restoration, and you can see the thickness of the tissue on the facial. Here's the crown placed on the implant with adequate inter-implant dimension and shape. And if you look, you can see on the occlusal view how wide our margin is. Part of that's because I'm placing it for a lingual cusp position, and part of it is because we've enhanced the tissue. And so if you look at the pre-op on the left and the post-op on the right, the gingival margin is higher on the implant, and we have good tissue thickness, and you can see how wide the KT margin is compared to pre-op. So that's a very regenerative procedure for really not doing anything. All I did was no forward closure, no primary closure, and a small apical repositioning at implant placement. Very beneficial. So if you carry that kind of a treatment philosophy forward in the aesthetic zone, you've got extra tissue to work with pretty routinely. And so on this occlusal view, you can see the difference in the positioning and the width of the KT margin. Okay. So here's an example of placing it over a graft, about 25% larger with an immediate implant and an overgraft. We'll tuck it into position. We'll hit it with saline and then tuck it into position. Make sure your instruments are dry and don't have blood on them, or it'll stick to the membrane, and then it's like getting a piece of saran wrap all kinked up. You can wet it and flatten it, but you want to be able to tack and place it. On this, I put the small triangle that I cut out onto the anterior to get an extra dose of growth factor on that interproximal where it had the most graft material. And then we did a pedicle rotation flap in between, so just a finger flap across that for closure. So the grafting and management with it around grafting is really easy. That's a case I showed was primary closure over and around an implant, but most always it's managed with non-primary closure. That's something that's a huge advantage because we're not coronally advancing the flap, we're not raising a flap most of the time, and we don't see obliteration of the vestibule. And it sets us up for a secondary procedure where that's indicated with a apical position flap, which enhances everything, and our restorative docs really like that. So I'm going to go into immediate implants, and we're going to concentrate mostly on molars, but here's an example of a case that I did probably 10 years ago, and you can see that there's mesiobuccal dehiscence of the soft tissue, so we know that means that the root's prominent, there's no bone, and that's why the tissue has the dip in it. So we're going to manage this case, and we're going to take out the teeth, do the implant site preps, do our intraoperative PA, this is before navigation, and now I place the immediate anteriorly and the delayed or healed site posteriorly. And now we've got a gap around the anterior fixture, so we're going to graft that with corticocancellous allograft mixed with autologous blood from the IV. And we've gained our dimension, and now we're going to cover that with the Amnion-Chorion tissue. So here you can see the BioXclude goes up on the abutment, so you can run it up onto adjacent teeth, tooth roots. You can do adjacent tooth recession management at the same time with BioXclude and a coronally advanced flap. There's a lot of things that enhances our ability to manage periodontal issues or recession defects adjacent to our implant site. And here's just an example of a case where we're placing it. This is what I showed you earlier, where the Amnion-Chorion is on the healing abutment and exposed, and then we watch it go through the healing. Here it is at 8 days. Already at 8 days, it almost looks like half the defect is gone, doesn't it? And we follow it at another 10 days, and you can see the improvement in the fill and the quality of tissue compared to the distal site, which was an apical position flap with lots of extra KT. And so as we go through the healing, at 4 months, the two sites look almost identical. Right? So the advantages that we get from having amnion and allowing it to improve our tissue margin is pretty significant. And I see this routinely, especially if you're using cuspal lingualized placement, where the screw access comes out in the cingulum or in the mid-fossa. If you're getting more buccal, it's probably not going to work as good with two buccal placement. Additionally, since this, I've mostly switched to dynamic navigation, and so I've been doing it for 10, 11 years, and it's something that's part of everything we do. It's definitely increased the accuracy and the quality of my work, and it's something that I can change on the fly if something isn't the way it is, but it's one of the more studied things, and this study with Mike Block and R.W. Emery was the pivotal study that got the system approved, and we did a lot of patients and a lot of implants over a 3-4 year period with it. So it to me is something that's really changed my practice. It's simple. The patients come in, we do a scan with a clip on it on the opposite side. The staff calibrate the machine. I do the plan. The plan takes 90 seconds to 3 minutes, depending on one implant or multiple implants. And it's pretty simple. And the other good thing is that I do sit-down surgery, and it allows me to sit up straight and have my neck and posture better, and probably got an extra few years of practice out of that, so that's a good thing too. So with that, in terms of managing immediate wounds, this is an example of a case doing an immediate molar and using BioXclude as part of the treatment. This is a pre-op for this patient, and you can see what we're gonna work toward. Here's the patient pre-op with a failing endo and a fracture. And this planning is unusual because look at where the metal foramen is. It's at the apex of the first molar. So a weird anatomic variant, but that's what we're dealing with. And so we've taken the tooth out, cleaned it because it has a fracture. I would use betadine, rinse it, and then re-clean and prep the site. And then we place the implant so that the screw comes out middle to slightly lingual. And once the tooth's out, you kind of lose your references. And so it's always more lingual than you think, or the implant always ends up being more buccal than you think with a reduced gap. And I think one of the keys in immediate molars is to have a minimum 3 millimeter buccal gap. And in doing that, I've been doing it for 15 years, and I've just almost never seen a complication with this kind of surgery. So we place the fixture, we take the Amnion-Chorion or the BioXclude here, we cut out a triangle, and then I place the triangle on the skinny side on the lingual, and I place the main part from the buccal and into the interproximal. And so you get just an idea, wet it, tap it into position, and then take a dry, that's a Molt 2.4. For anybody that's been around a while, that's actually a Terry retractor, but it's like a Molt 2.4. It's from when we used to do tunneling for HA way long time ago. So here you can see you just fit into position, and then you take and do the upside down sutures like we talked about before. So you come from, this case, a lower right molar. We're coming from the buccal aspect of the lingual flap, taking the stitch, coming through, and then back out from the palatal or lingual side of the buccal flap through and tying an upside down suture. What I want you to see on the far right is that the sutures aren't in the papilla. The sutures are like a bungee cord to hold the tarp down on your pickup when you're going to the dump. You want it to be over the best place to keep the amnion down so the patient can't rinse it out if they go home and rinse too vigorously. And so that's the biggest challenge with this, is making sure that the patients understand that, hey, no swishing, we mean no swishing, not even when you're eating dinner, don't take a swish of water and clean your teeth. That's the only thing I've seen once or twice a year in all the immediate molars that I do. Huge, predictable, non-owie. They leave like that with the healing abutment in position, and just post-op CBCT, you can see the position and the dimension of the buccal gap at the buccal bone. And here's 10 days after surgery. So almost no inflammation, and you can hardly see it. This is a patient after 22 months restored, and you can see the width of the KT. You can't tell what's an implant, and you can't really tell that we were there. So this is a process going through for this, and look at the tissue height as it comes back around the site with the BioXclude. It really enhances the tissue growth. So immediate post-op through restoration. So I think this is just a game changer. This is something I do 4 or 5 times a week in my practice, and immediate molars are just a slam dunk with this kind of a protocol. So let's look at another challenging case. This patient has a stinky impacted third molar and needs a second molar implant placed. And so when we go in and clean it all out, we've got a huge defect at our third molar site and a normal defect at the second molar, but we're missing that little bit of bone bridge on the distal. So one way that I've found to work around that is to use navigation like normal to place the implant. I had to take away a little bit of the buccal, mesiobuccal root to get the root part out. And now I've got to fix this defect. And so I'm putting an LPRF. It was close to the nerve, so I put the LPRF on top of the nerve. And now I'm going to take a product that I didn't really think would have much application, but I've changed my mind. This is a porcine collagen, 70% graft, porcine xenograft, and 30% collagen. And it's a sponge and it soaks up, and now I've got containment of the graft. So I'm going to place that into the wound like you can see on the right-hand side, cover it with BioXclude, and now I'm going to use that as my posterior wall, and I'm just going to graft the immediate implant. And so that's what we did. You can see now the cortical cancellous around the implant, and you can see the Amnion-Chorion cut to fit around and over the back of the defect. And now we've got near primary closure over the third molar site, and we've mildly advanced the flap on the distal of the second molar because it was loose, so we took it. So here it is looking from the side and over the top, immediate post-op. So watch how this heals. This post-op showing the CBCT and the positioning. Here it is at probably 9-10 day window. Not a lot of inflammation, everything looks like it's laying right. Patient's been so careful, they've still got the slough of the epithelium on the KT margin, you can see there. So a very careful patient. Here she goes through a little bit more healing, and here it is restored. So that third molar defect adjacent to a second molar can be an issue, and by using the collagen-based product with the porcine xenograft, I was able to manage it all as a single surgery. Okay. So here's post-op CBCT just showing fill of the defect. Well, what about upper molars? So this is a case where the patient's losing a distal molar and the site is marginal. She has a little bit of periodontal disease going everywhere. So we're gonna plan her for placement of the implants. And with that, we're going to place 3 to have a single crown and a 3-unit bridge. So we get the teeth out. She has moderate perio and a real heavy smoker, almost yellow fingers. And so with the teeth out, we've done normal navigation and we're using an osteotome just to bump the 2 sites mildly because she needed just a 2 mm bump for placement. Fixtures are placed and you can see the ISQ readings on immediate, and the second fixture is the same reading as the immediate in front of it, and it's from the healed ridge with an apical flap here. So now we graft around the margins of it, cover them with BioXclude, and here is the initial closure. And see on the far right screen, this is the case that I showed you that filled in. So you can see the Amnion-Chorion that's on it from the buccal all the way up onto the healing abutment. Okay? So you can't do that with any other membrane. And so here she is after 10 days. So with her heavy smoking, using this kind of a procedure with Amnion-Chorion tissue, you can see the initial healing and it's already about half covered. And here by 4 months, it's completely covered and level. So what I did, because of the dentist I was working with, I changed that healing abutment out to a 5 mm wider emergence to give it a little more tissue sculpting, and then he took it from there with a provisional. And this is a final restoration on day of insertion. So you can see we went from the tissue being level with the implant to now being 4 mm at least above the implant height. And so just a quick summary of what we showed you there going through. And so the second image from the right is when I changed the 3 mm to a 5 mm extra wide. So that's going to make the tissue wider and pull it down. I had a number to do it. So that's what we got. So I think you can see looking at this that it's a very rejuvenative process, and the growth factors are in it, the antibacterial components let me get more and more things done with a single surgery and with a less invasive approach. Our patients like one surgery, don't they? They really do. Question is, can we do it predictably? So let's look at some other things. Here's another way to manage the sinus crest using a drill stop system. And so this is a case that we took out a molar, and if you look at the tooth behind it, number 15, there's a part vertical periodontal defect on that. And so we took the tooth out, did a small bump after the sinus floor drill technique, and now I didn't show you, but I did an open flap root surface preparation on number 15 with curettes. You guys have those, don't you? Yeah, they're helpful. So I went in, cleaned the root surface, prepped it, and then did the bone graft like I'm showing. So here you can see, I think I did put it in. So you can see where I opened it up, exposed that, and cleaned the surface. I didn't remember putting that in. So then we cover the graft with the Amnion-Chorion tissue, and now we suture it. So it's just placed back into position, and here I'm using chromic. So if you're doing a molar socket graft, I wouldn't generally use chromic because there's too much of the glutaraldehyde in the stitch, but on a smaller wound like this where there's less gap and less exposure of the placenta, placental tissues, I think you're fine to do it for that. So I think it's just careful use of chromic. So here the patient goes through healing. You can see healing in and around the site, and you can see that it's filling in, and at 1 year you can see that the distal defect is even more filled in and looking more toward normal. So what other applications can we think of for using this kind of product? So we'll go through a number of different kind of applications. In tunneling, I use it, I place it as a single layer over top of the tunnel graft. And so I grasp it in a forceps and push it all the way to the end, put my fingers on top and bottom of the instrument holding it, so I tack it down and pull the instrument out, and it gets one nice layer of growth factor all the way across it. So I'll show you just a case. Here's a patient that has, you know, pretty typical congenitally missing laterals with defects that are associated with that. Look on CBCT in the cross sections, and you can see the concavity and the minimal volume worse on the right than on the left. And it's interesting because the less bone base you start with, the less graft you can get. Bockley says you have to have bone to make bone, and I agree with them. The smaller amount of bone you're starting off with, the less you're going to get in your final result. So if we look at this, this is tunneling, this is your instruments that I use, and the one thing that really does make a difference is I found that if I go all the way up the ridge crest and I go over the top of the alveolus onto the palate and release it, I can get better graft take, and I can get a fill with width right at the crest, not a big round bulge that's shy of the crest. And so that's what I'm showing here, where my finger is feeling it, and I run it up, and I almost detach the gingiva from the teeth. I bump it just to where there's the last 3 or 4 cell layers holding it, and that gives a little more room and mobility to pack it. And I use it a lot in immediate implants now. Instead of adding CT, I can do a vertical tunnel and augment it pretty simple and fast. So this again shows the amnion being put in position, a single stitch. And you get some ecchymosis depending how much you're stretching, but look at both the ridge crests. It allows me to get a wider volume of bone at the crest, which is very helpful, okay, in addition to it everywhere else. So we work through healing for her, back to navigation, placing the implants. Here we had to do some laser modification, and the referral doctor did some provisionalization, and the patient finished up quite nicely with the restoration, and it's I think a pretty straightforward way. The other good thing about tunnel grafting is a lot of times if you're seeing kids in this age group, it's 14, 15, 16, 17, you don't want to do aesthetic implants for another few years. When you do the tunnel and you include a high temperature xenograph, a year is minimum time you want to wait, and that's a stable tunnel grafting for 3-4 years later. So you can do it at the time of the thirds and still have a good augmentation when they hit a more appropriate window for timing for aesthetic management, if that makes sense. So here's how she finished up. And I'm going to show you now a ridge expansion case. Any questions on what we've done so far? Sure. Can I do what? Sorry, I can't hear you. Okay.
Yes, sir. Can you elaborate a little bit about the tunneling technique? Because I need to understand it a little bit better, because it looks very good here, but I never did it.
I'm happy to talk with you. Oh boy, this isn't going to work. Okay. I'm happy to talk with you after, but I'm not teaching a tunneling. I'm showing you multiple categories, but basically make a midline incision, homozade, vista, backed up to the canine, to the nasal floor, and you graft that whole interdimensional space.
And then you put the membrane?
And then I cover it with the growth factor
Okay.
to
Thank you, sir.
get a single layer in. Any other questions? Okay, and then we'll keep going. Where do I stand that's safe? I have to stay on the podium. Yeah, well, I can't even come on the right side or we get a squawk. Okay, so I'm going to show you an example of a ridge expansion case. And so we're going to take a jaw and we're going to make a cut in the bone. We're going to bend the bone and place a fixture and then manage it. So here's a posterior case, which is a relatively easy case in the maxilla. Bending around the canine is impossible. You cannot bend on a curve. So you have to make the cut before or after it on purpose and have it with a continuity defect where you want, or you will break it on the canine, just as a aside. But here you can see on the coronal, on the CBCT cross sections and axial, we've got dimension, we've got marrow space, we've got some undercut. So it's a perfect kind of case to manage with ridge expansion. So we're going to take and do a partial flap exposure. I do a palatal incision, so I have the extra tissue to apically position. I only dissect it just to the ridge crest, so I don't have to expose any more than I need to, at least for that initial phase. Make cuts with a piezosurgery. This is that's a OT7S, that's an OT7. I typically use an OT7S4 because it's 0.35 thick and you don't lose it. Then we use different kinds of expansion instruments that are longer before they get wider to get the whole bone flap moving. And then we mobilize it and are able to make a gap. So you can see it opening up with insertion of an osteotome. There are ways to do it with other kind of burrs, but they tend to take more surface prep and have more heat issues on the margin. But here you can see with the osteotome, we're able to expand it, and also where the green arrow is, if I expand it from that normal bone flap, it'll be too far to the facial. So I had to take away a palatal purchase so that part of the implant width is compensated for, so the screw's in the right place. So with ridge expansion, you can move it too far buccal and end up with a thinner bone flap. So here's the two implants in position. You can see the immediate on the front, the expansion on the gap on the back, and now we're going to take and do a limited crestal elevation just below the height of contour, and we're taking a small and large particle porcine graft and blending it with autologous blood from the IV. It's the easiest, cheapest, most effective way to do it. The larger granules, there's data that shows that the larger particles maintain volume better than small. So a hybrid of large and small is the best in my experience. So you can see the contour that we've now filled with the porcine xenograft, covering it now with the placental tissue. So we're taking the BioXclude, trimming it roughly to shape, oversize, and around the implants, covering it with a single layer, and now we're going to close it. So this is just showing the initial incision with piezosurgery and with a distal beveled release, and then mobilizing it with the various expanders. So you can see the bone bending, and then it snaps back when you pull the instrument out. Yeah, so we keep working through that, eventually mobilize it enough to place the fixtures. Here's now adding the graft in, so a limited coronal dissection. I'm just using up all the slack of the palatal incision I did. So I got 4 more millimeters. This fills it in nicely with graft and it lays right back down. Here we're covering over it with the BioXclude like we showed you, and then we close it up with PTFE sutures. So it's really a simple kind of procedure. I'm able to do an augmentation graft. The extra tissue I have from making the palatal incision is in essence an apically positioned flap, and it's real simple. It just fits together just like a charm. So you can see on the post-op image the buccal dimension that we have and the change on the right side from the pre-op to the post-op. So this has just been a real straightforward, simple, but most important, it doesn't hurt. It's much less owie than it is with a conventional kind of graft. And when we add the BioXclude to it, it reduces inflammation and pain. So here's how the patient finished up with the restoration. and we'll look at another case in the mandible. Here's a patient with a moderate to severe horizontal defect. So we've still got a buccal anatomy with a concavity and some crestal bone height, but if we try to put implants in, we're not going to have the implant encased in bone. And so it's not a matter of a couple of threads, it's just not wide enough. So we're going to use a technique I learned from Dr. Greenwell, a periodontist in Kentucky, and it's a superficial split thickness flap, and I'll show that to you. It's really helpful to get out of trouble if you need primary closure. And so if you look on the initial incision, we've done a full thickness flap with probably 4 millimeters, 5 millimeters exposure. Then we're taking a blade and making a cut on the periosteal side, and we're doing it perpendicular to the buccal tissue. So instead of going down apically with a vertical release, we're coming out and keeping the buccal soft tissue superficial, going like this, above the nerve. So if you're in the mental foramen area, you're above the height of the nerve, and you're only in the tissue. So it's thinner, so it's called a superficial split thickness flap. And you can see on the far right, the periosteum on that level where the green arrow is, that's showing the level of the flap where the cut is, and you can see the periosteum and mucosal tissue getting thicker. So I refer you to that IJPRD in 2004. It's a great technique to get out of trouble. Here a couple of screws are placed for tenting for augmentation, so I'm going for 4 to 5 millimeters. How often do we get in trouble when we do 4 or 5 millimeters? Not very often. So I'm not asking for a lot. I've done a limited dissection. I've got 2 screws. Now I'm going to place the BioXclude on the bone. And you go, are you crazy? Well, it's not a barrier, guys. It's a growth factor carrier. And so I'm putting it on the bone side to signal to the bone to come heal it. And then I'm going to place it after the graft is in. So the superficial split thickness, we're keeping that inferior margin on the periosteum as containment, so I don't have to have a barrier or tax because the periosteum is containing the graft. Okay, now we pack it in, and now we cover it with placental tissue, and now we're going to put a collagen barrier on it. So I've trimmed the collagen barrier to shape, soaked it in autologous heme. I want it in blood product. If I had LPRF, I would use LPRF fluid, but I don't want LPRF because I want the graft as dense as I can. I just want straight blood and graft material, and the amnion gives the growth factor without taking up any space. So it's a different way of thinking about what we're doing. So a suture across it holding the periosteal margin and the Amnion-Chorion tissue as a compact graft. And now we're going to take and cover that with one more layer. So here's the series. You can see the periosteal inferior margin, the Amnion-Chorion, the graft, the collagen in place. And now we're covering the final wound with another Amnion-Chorion. So there's 3 layers of growth factors in this wound. So the closure is there. You can see the volume difference just looking at it from the occlusal view. And the only disadvantage of the superficial split thickness is, see how it's got a little bit of petechiae in it? It gets a little more bruising because you're more toward the surface with the release, but you can use it anywhere to mobilize the tissue without having to go deeper, especially if you're near a nerve. So it's a thing I learned from Greenwell a bunch of years ago, and it's been real helpful. So here you can see the post-operative scan with the volume change. And so the periosteal dissection only went to that height of the contour of the undercut, and now the periosteum is containing the graft. So I don't have to use screws. I don't have to come back and take out pins, tacks, that kind of deal. So it really, I think, makes it simple. So here we go through healing. Now it's surgery, and you can see the bone levels right where the screws are. So a nice volume maintenance for the graft. We take out the 2 screws, do navigation, place the implants, harvest a couple of cores, and we see that we've got really good new bone formation. So here's it with the implants in place, with the bone margin. And now when you do open up the flap on top of a graft like this, I think it's helpful to put another layer of graft and cover it again with amnion when we do the apical positioning. So the implants are in position, we place the healing abutments, and now I've filled it in with a little bit of graft and placed another layer of amnion, and now we're going to apically position the tissue, and just a simple finger flap, just a Palachi flap between to get near primary closure over the center. Okay, really straightforward. It's not owie, it's not rocket science. It's just using what the patient's giving me without having to put him through a whole bunch. So this patient had 2 surgeries, and she was done in about 9 months, okay, maybe 8 months. So here you can see again the volumes after healing and the change in tissue after we've done the second stage. And at 7 days, look how nice it looks. It just has little inflammation and really does well. So here's at 4 months prior to restoration, and here's the patient restored. Okay. So here's an application that we all could run into that's not necessarily implant related. This patient had osteotomies and has a big cystic lesion and an apical abscess up around number 8 and 7, and it's involving it into the nose. So there's 2 locules, one's from the abscess in the tooth and the other's something related to the plate, and it's all going into her nose floor. And so looking at the axial views, it's through and through on part, and it's right up and into the nose floor, as you can see on the far right there. So our plan is to go in, get the plates out, clean the mess out, and I want to do everything I can so next surgery I can put implants in as single stage and be finished. So we're going to go in, clean out all the mess, go around it. From here I've dissected from the vestibule to the ridge crest to make sure I got all of that material out. And now we're going into the nose, and you can see all the granulation and yucky tissue that's there. So we've got it all cleaned out to the nasal floor. So now when we're at the nasal floor, what's the best way for us to fix that and graft it? We've got these 2 big holes in part of the nasal floor and nasal wall missing. So I'm going to show you again. I went back to this kind of graft material. I've covered up the name so you can't see the name, but this is a large 70% porcine, 30% collagen. It's stable. I soaked it with blood, and I used it to hold the nasal floor and wall in place. So I shaped it, put it in, and I don't have graft particles going all over the place in the nose or into the vestibule, especially with the patient's mobilization of their lip and talking and wiggling. So we packed that in, covered it with Amnion-Chorion first, placed it into position, covered it, and then grafted the crest. So I like this product because I don't have particles all over the place, and I can trim it and shape it and pack it, and it'll stay where you put it. So I think it's a real help. So here you can now see after the nose floor is redone, we covered it with Amnion-Chorion or BioXclude, and now we just zip the patient up. A few chromic sutures. Pretty simple, pretty straightforward, and making use of products that allow us to not have loss of containment and to upregulate the wound healing was pretty significant. So here she is after 7 days, all right? Very little inflammation. You see that consistently with the BioXclude and the Amnion-Chorion tissues. They're really, really helpful for healing. There's another 2 weeks, and then here's 4 months. Okay, so with that, we then went back in because 7 had so little root on it. We managed that site now with implant planning, placing implants in 7 and 8 positions, 7 as an immediate into the healed defect. So you can see those contours. So 7 is an immediate, 8's into the healed site, and you can see the bone volume, and I think I just added a little bit more to the bone volume on the buccal because the flap, by doing that palatal incision, I get an extra 3 millimeters, so I fill it up with bone every time. And half of it goes away, but the other half stays and really helps with the contour, especially in a high smile line kind of patient. So here's the soft tissue apically positioned, the rotation finger flap in between the 2, and you can see the post-op radiograph and positioning, and look at the bone volume that we were able to get on both these fixtures. So to me, it's a real benefit to be able to upregulate wound healing, enhance it, and be able to do a palatal incision apical position flap that you fill in with bone graft. So to me, the utility of it's really high. So Who wants to treat this defect? So post-ameloblastoma resection, bad scarring, mental nerves right underneath it. And this is how she started her initial presentation after a biopsy at the periodontist office. So for here, what I wanted to show you is we're going to use a large CT graft in this area to try to get some semblance of a vestibule for this patient, and then we're going to do a full arch treatment on her secondarily. So we harvested a pretty honkin' big CT graft from her palate. Yeah. So you can see it's in. I used barricade dressing to cover it, and this is the size of the palatal void. So this is a great place for BioXclude. So I placed 2 pieces in it, and I just did upside down sutures like I showed you with this. This is glycolon, and it's really thin, but it does resolve. So it's kind of like Proline, but doesn't have the memory, and it's resorbable. And so that's my go-to suture for a lot of things. I had them make a stent for her to help cover it so it wouldn't be so painful. Well, guess what? She thought it was less painful not wearing the stent. And the stent only covered part of it, and the part where she did wear the stent didn't heal any better than the part where she didn't wear the stent. And she didn't have that much discomfort at all. She was pleasantly surprised. So I've found that covering over open wounds like that is a huge advantage. They just can't swish or rinse too hard to knock it loose, but it does tack and it does get gluey and does stay down. Okay? So back to our wound in this patient for management. And so we've improved it, not as much as I'd like, but I couldn't go deeper because the metal foramen was right where the worst part of it was. She went through and we did full arch on her, and she finished up quite nicely with it after her resection. So another application of it. Well, what about in doing crestal work and crestal sinus elevation? So if you've known me, that's pretty much all I do. I haven't done a lateral wall graft in 7, almost 8 years now. And so the crestal techniques really give me a real good opportunity to do a minimally invasive, non-owie kind of surgery. So in this kind of application, we're going to show raising a section of the floor called a contiguous elevation. So we're going to raise a 4 by 10 millimeter square or rectangle. 4 millimeters is still enough width to get engagement with a 5.5, 5.8 kind of an implant and get primary stability. And with a 2.5, 3, 4 millimeter residual height, we can put in a 10 or 11 millimeter implant. So here's an example of a case without an implant, but we're going to use this technique. She's got a septa. So if we did a lateral graft, the septa makes it more risk for tear. But if we do a crestal, this septa's going to help because it's my back wall of the defect. I can get free 8 millimeters, 6 millimeters of elevation from the septa. So we make a crestal window with the piezosurgery, mobilize it, tuck it, push it up, and add graft to it. Tease it free, add graft. All I do is cover it with a Amnion-Chorion BioXclude and sew it back in position. So the molar, the original extraction site's still open. And you can see in the post-op image, we've just packed it with graft material in that part. So the release is pretty simple, and you can see it granulating in over the anterior extraction site. So this is a patient coming back at probably 6 months, if I'm remembering correctly, and you can see the contour. We've got plenty of graft material, pretty easy to put in an implant there. We work up on planning. Comparing to pre-op, we've now got a very nice width and height of bone, and to stick a fixture in is pretty straightforward. So let's look at one other application with crestals, and this is a patient that has a pretty significant pneumatization at the first molar. It's not terrible, it's not only cortex, but that gives us that 2-3 millimeters of marrow space is enough that an implant can be placed there and regenerate from. So we're going to go in and take out the second molar, planning the implant. You can see it's pretty tall, and you go, geez, can you do that from a crestal? Well, show you some tricks. So we made the same incision, way to the palatal to have all that extra keratinized tissue. We expose it down. We use the piezosurgery to make a window deeper where it's deeper and shallower where it's shallow, taking a concave osteotome and doing initial fractures. To the posterior, I'm bending so that the break is always perpendicular to the sinus floor. So you've got a mesial slope and a distal slope, so you have to line it so you're perpendicular to it. Now we're using a contiguous elevator, and what that allows us to do is do a broader force and gently mobilize and manipulate it and elevate it. You can see us working through the diameter, so it's 2 by 10, 3 by 10, 4 by 10, and then we start adding bone once we've got it partly mobilized. The majority of the mobilization should be done with the bone, graft, blood mixture. It gets all gooey and greasy, so it's like hydraulic grease, and so you keep the pressure and tension more even across the site. And so again, you can see the steps, adding the bone graft and mobilizing it, pushing it up coronally. And here's now the second phase. So we're adding graft, going to use the instruments to push it up. Gentle malleting, usually with sedation. But you can see the height of the instrument. You can see another 9 millimeters of graft material on the PA. Doing nose blow tests to be sure we don't have a tear. And now I'm going to the site-specific osteotome to prep it before I place the implant. Now I'm using navigation, screwing the implant into position so I know that it's where I wanted it. And then we've got the implant in with the crestal adjacent to the graft. So now here's just again a summary on the regular slides with that addition, placing the fixture, and with a significant elevation in the sinus. Now we graft everything, fill it all in with bone graft into the second molar area, and now we're going to do an anterior apical. So we're doing a vertical release on the front so that the tissue that you can see between the forceps, that used to be on the very the very palatal mesial corner. So we're going to move that down and take a finger flap off it to get closure. So you can see the graft in position. Now we've covered it with BioXclude, and that's our growth factor enhancement. And now I've done a pedicle finger flap, moved the flap forward and anterior, and then closed the distal defect after. So we're taking that whole buccal flap, we're pulling it down. So it used to be palatal, we're pulling it down and then moving it forward and then pulling the tissue to close over. So we have a near primary closure over the second molar site. You can tell from positioning that's going to be great for a final crown restoration. You can see the volume of the bone in there. I probably could have gone with a little longer implant, but looked good. And you can see on the axial view, the little dome of bone that's above the implant as we're coming down in those axial scans. So here's the patient at 10 days. It's pretty impressive to me how it heals with the Amnion-Chorion tissues, the limited inflammation. And so you work through, here's the 4-month healing, and then the patient gets their final crown and restoration. And yes, even in Idaho, we don't have everybody get all their abutments seated properly. Yeah. So I thought that only happened in New York. Yeah. So go through a year later, sent her back to the dentist to refit the abutment. He said it was fit and it was perfect, and so what are you gonna do? So that's an example of another application. So as we look at it, the placental tissues, specifically BioXclude, is packed with tons of growth factors and cytokines that help upregulate wound healing, okay? They give us a margin of safety and improvement in the wound that we can't get predictably with other things. There is donor variation, but these are all pre-screened C-section live births. It's not an aborted tissue. And these donors are screened and it helps reduce pain. It's antibacterial. And so to have something that reduces pain, is antibacterial and cuts inflammation, I mean, that's just a winner all the way around with something that I can take off the shelf and put in a patient that doesn't take up any space. It heals by the epithelial cells coming across it, acting like the basement membrane. So we are going to get a less deep wound than we are with any other healing with PTFE, which I use, with LPRF, which I use. It goes down and underneath because that's the superficial part that acts like a scab. So that little bit of advantage with the tissue is huge, especially in high-end, high-smile, thin biotype kind of patients. So I showed you this kind of an example of an apical flap, full thickness, with an anterior defect, with the placental tissue put right on the healing abutment, and we saw how that went through healing and how we had such a good margin. I showed you a case where the 3 millimeter healing abutment was exposed, and by the time we were at 4 months, it was completely covered. And so to me, this lets me do things that I can't do any other way. So it's immunoprivileged tissue, it's anti-inflammatory, antibacterial. It definitely accelerates wound healing and cuts expense, and it's a very simple way for me to use this to enhance healing, to have a single surgery for the vast majority of the cases that I do with little owie and very happy patients.